not to rush to the stethoscope, but rather to observe the infant carefully. You can note several important aspects of the respiratory examination simply by observation, including respiratory rate, color, nasal component of breathing, and audible breath sounds, including nasal flaring, grunting, or retractions, also known as chest indrawing. Chest indrawing is the inward movement of the ribs during inspiration. Any of these signs of work when breathing indicate respiratory pathology. Percussion is not helpful in the examination of the chest of infants, as the infant's chest is hyperresonant throughout. Next, begin auscultation. Breath sounds are louder and harsher in infants than in adults because the stethoscope is closer to the origin of the sounds. Also, it is often difficult to distinguish transmitted upper airway sounds from sounds originating in the chest. Hold your stethoscope in front of the infant's nose and compare the quality of sounds. Also, compare the loudness of the sounds as you move the stethoscope further down the chest. As with adults, note the symmetry of breath sounds from right to left. Sounds transmitted from the upper airway become quieter. Note whether any sounds are inspiratory or expiratory. Expiratory sounds are generally from an intrathoracic source, while inspiratory sounds can be either from the chest or from the upper airway or nose. Sounds are transmitted loudly throughout the infant's small chest. Nevertheless, the characteristics of the breath sounds, such as crackles, wheezes, and rhonchi, are the same as those for adults. Wheezes, rhonchi, and wet crackles are commonly heard in the chests of infants. They commonly result from various lung infections, and much less commonly from cardiac disease. Carefully observe the skin for cyanosis. The best place to ensure that the infant is pink is to look in the mouth. A true pink, the color of a strawberry, is normal, while cyanosis appears more like the deeper red of a raspberry. You already observe the infant's respiratory rate. This is an important component of the cardiac examination as well, because peaceful tachypnea often accompanies heart disease. Palpate the peripheral pulses. This is particularly challenging in squirmy, chubby infants. The brachial artery pulse in the antecubital fossa is easier to feel than the radial pulse at the wrist. It is also important to feel the quality of the femoral pulses to rule out coarctation of the aorta. The femoral pulses lie in the midline just below the inguinal crease, between the iliac crest and the symphysis pubis. Take your time when palpating the femoral pulses. One trick is to flex the infant's thighs. The infant will likely stretch them out a bit and allow you to palpate in the inguinal canal. You should also try to palpate the dorsalis pedis and posterior tibial pulses, although these may be difficult to feel. The point of maximal impulse is often not palpable in infants. Next, place your hand on the chest to feel for thrills, which are quite rare in infants. Auscultate using the diaphragm of your stethoscope in all areas, including the second right interspace, or aortic area, the second left interspace, or pulmonic area, the left lower sternal border, or right ventricular area, and the apex, or left ventricular area. While the specific order is not critical, it is important to auscultate in all areas, listening carefully for S1, S2, S3, or S4, and any murmurs. Now repeat using the bell of your stethoscope. Infants commonly have premature atrial or ventricular beats that sound like skipped beats. These will usually go away when the infant cries and the heart rate increases. If you can auscultate while the infant is very quiet, you should be able to detect the splitting of the second heart sound, or S2. Detecting this split eliminates many serious congenital cardiac defects. Third heart sounds are low-pitched, early diastolic sounds commonly heard in infants. They reflect rapid ventricular filling and not disease. You might even hear a gallop in the presence of a normal rate and rhythm. This is normal in infants. Remember that infants breathe rapidly, so you'll need to mentally subtract the sounds of respiration from the heart sounds. Listen for the intensity of the second heart sounds. Listen for systolic or diastolic murmurs, as well as third heart sounds. Fourth heart sounds are rare in newborns. Listen carefully for heart murmurs in the axillae and also in the back to help you identify pulmonic murmurs. The breasts of both the male and female newborn are often enlarged as a result of the effects of maternal estrogen. Such enlargement may last several months. The breasts also may be engorged with a white liquid, sometimes colloquially called witch's milk. This finding may last for the first week or two of life. You will find it easy to examine the abdomen of infants because they love to be touched. Inspect the abdomen with the baby lying supine. First, observe the shape and symmetry of the abdomen, as well as the umbilicus. In young infants, look for redness or swelling around the umbilicus. You may notice a diastasis recti in many normal infants. This is a separation of the two rectus abdominis muscles, causing a midline ridge, especially on contraction of the abdominal muscles. As in adults, auscultate the abdomen prior to palpation. Don't be surprised if you hear an orchestra of musical tinkling bowel sounds. A useful technique to relax the infant is to hold the legs flexed at the knees and hips with one hand while palpating the abdomen with the other. You may also want to request assistance from a parent, or use a pacifier or bottle to quiet the infant in this position. Start gently palpating the liver in infants low in the abdomen, moving upwards with your fingers. This technique helps you avoid missing an extremely enlarged liver that extends down into the pelvis. With a careful examination, you can feel the liver edge in most infants 1 to 2 centimeters below the right costal margin. Similarly, you can usually palpate the spleen tip. In fact, you may be able to palpate the kidneys of infants by carefully placing the fingers of one hand in front of and those of the other hand behind each kidney. Begin examination of the infant male genitalia with inspection. With the infant supine, note the appearance of the penis, testes, and scrotum. Then, unless the infant's penis has been circumcised, examine the foreskin. Note that the foreskin of infants cannot usually be retracted. Examine the penis, noting abnormalities. Make sure the penis is straight. Examine the scrotum and testes, making sure you can feel both testes. Note any swelling within the scrotal sac. In the newborn female, the genitalia will be prominent as a result of the effects of maternal estrogen. The labia majora and minora have a dull pink color in light-skinned infants and may be hyperpigmented in dark-skinned infants. The hymenal membrane of newborns is thickened and may have tags projecting out. Familiarizing yourself with the appearance of the genitalia at different ages will help you recognize normal variations from subtle abnormalities. For infants, the rectal examination consists of visual inspection of the anus. Digital examination is not routinely performed unless pathology is suspected. Much of the musculoskeletal examination focuses on detection of congenital abnormalities, particularly in the hands, spine, hips, legs, and feet. With a little practice, you will be able to combine the musculoskeletal examination with the developmental and nervous system examinations. The infant's hands are clenched because of the palmar grip reflex. You will need to help the infant extend the fingers. Inspect the hands, fingers, and elbows carefully, noting any defects.
Good. Stretch. Stretch. Good boy. Hips.
Examine the infant's hips carefully for signs of dislocation. 2 techniques are especially helpful. For the Barlow test, hold the legs as shown and rotate your hands outward, seeing if the femoral head feels stable or moves laterally. Movement of the femoral head signifies laxity and a dislocatable hip. For the Ortolani test, again hold the legs as shown and rotate your hands the other way, inward, until each knee touches the table. A palpable movement of the femoral head back into place is abnormal. It is important to examine the legs and feet to detect developmental abnormalities. Assess symmetry, bowing, and torsion of the legs. There should be no discrepancy in leg length. Some normal infants exhibit twisting or torsion of the tibia, inwardly or outwardly on the longitudinal axis. Parents may be concerned about a toeing in or toeing out of the foot at an awkward gait, all of which are usually normal. Tibial torsion corrects itself during the 2nd year of life, after months of weight-bearing. Finally, examine the feet of the infant. At birth, the feet may appear deformed from retaining intrauterine positioning, often being turned inward. Manipulate the affected foot. A normal foot should be easy to correct to the neutral and even to an overcorrected position. You can sometimes scratch or stroke along the outer edge of the foot to see if it assumes a normal position. The normal infant's foot has several features that, while they may initially concern you, are benign. The foot appears flat because of a plantar fat pad. There is often inversion of the foot, elevating the medial margin. The infant may exhibit adduction of the forefoot without inversion, or even adduction of the entire foot. Each of these normal variants tends to resolve within 1 or 2 years. Finally, inspect the spine carefully, making sure there are no pigmented spots, hairy patches, or pits. The examination of the nervous system in infants includes techniques specific to their particular age and is highly dependent on several factors. Internal factors affecting findings include alertness and timing with respect to feeding and sleeping. External factors affecting findings include the presence of parents or the presence of fearful stimuli. Primitive reflexes are present only at certain ages and then disappear. Neurologic changes often present as developmental abnormalities. For this reason, neurologic and developmental examinations often are combined. Assess the mental status of infants during alert periods. If the baby is transiently too drowsy, return at a later time. First, assess motor tone by carefully watching the infant's position at rest, and then testing resistance to passive movement. Assess tone as you move each major joint through its range of motion, noting any spasticity or flaccidity. Hold the baby in your hands to determine if the tone is normal, increased, or decreased for age. You can test for the infant's sensory function only in a limited way. Test for pain sensation by flicking the infant's palm or sole with your finger. Observe for withdrawal, arousal, and change in facial expression. Do not use a pin to test for pain. Testing an infant's cranial nerves requires special methods that differ from those used for older patients. Cranial nerve 1, which mediates sense of smell, is difficult to test in infants. Cranial nerve 2 mediates vision. Cranial nerve 2 can be tested by having the baby regard your face. Look for facial response and tracking. Cranial nerves 2 and 3 control response to light. To test, raise the baby to a sitting position to open the eyes. Use a light and test for optic blink reflex. You may also use the otoscope without a speculum to assess pupillary response. Cranial nerves 3, 4, and 6 mediate extraocular movement. These nerves can be tested by observing tracking as the infant regards your smiling face moving side to side. Use a light or a toy without sound for this test if necessary. The motor portion of cranial nerve 5 innervates the muscles of mastication, while the sensory portion mediates facial sensation and the sensory part of the corneal reflex. Cranial nerve 5 can be assessed by testing the rooting reflex and the sucking reflex. Cranial nerve 7 innervates all muscles of facial movement and expression. Cranial nerve 7 should be assessed by observing the baby crying and smiling, while you note symmetry of the face and forehead. Cranial nerve 8 mediates hearing and vestibular function. Cranial nerve 8 may be assessed by testing acoustic blink reflex and tracking in response to sound. Cranial nerves 9 and 10 mediate the sensory and motor functions of the palate, pharynx, and larynx. These nerves are assessed by observing the infant's coordination during swallowing. Cranial nerve 11 innervates the sternomastoid muscles and upper trapezius muscles. Cranial nerve 11 is assessed by observing the symmetry of the infant's shoulders. Cranial nerve 12 mediates motor functions of the tongue, affecting articulation of words. Observe coordination of swallowing, sucking, and tongue thrusting. The deep tendon reflexes are variable in newborns and infants because the corticospinal pathways are not fully developed. Thus, their exaggerated presence or their absence has little diagnostic significance unless this response is different from results of previous testing or unless extreme responses are observed. To elicit deep tendon reflexes of the biceps and quadriceps, use the same techniques as you would for an adult, substituting your index or middle fingers for the neurologic hammer. However, the triceps, brachioradialis, and abdominal reflexes are difficult to elicit before 6 months of age. Although a normal flexion plantar response is obtained in 90% of infants, a positive Babinski response to plantar stimulation, that is, dorsiflexion of the big toe and fanning of the other toes, can be elicited in some normal infants until 2 years of age. The infant's developing central nervous system can be evaluated by assessing infantile automatisms, called primitive reflexes. These develop during gestation, are generally demonstrable at birth, and disappear at defined ages. A few of the more important primitive reflexes include the palmar grasp reflex. Test for this by placing your fingers into the baby's hands and pressing against the palmar surfaces. In infants up to 3 to 4 months old, the baby should flex all fingers to grasp your fingers. The rooting reflex. Stroke the perioral skin at the corners of the mouth. In infants up to 4 to 6 months old, the mouth should open and the baby should turn the head toward the stimulated side and suck. The Moro or startle reflex. Hold the infant supine, supporting the head, back, and legs. Abruptly lower the entire body about 2 feet. In infants up to 4 to 6 months old, the arms should abduct and extend, hands open, while the legs flex. The infant may cry. Absent primitive reflexes, or retention of those reflexes past the usual age they disappear, may signify abnormalities. General indicators of central nervous system disease during infancy include abnormal localized neurologic findings, asymmetry of movement of the extremities, failure to elicit expected primitive reflexes, late persistence of primitive reflexes, re-emergence of vanished primitive reflexes, delays in reaching any of the following developmental milestones: gross motor, fine motor, cognitive and language, and social and emotional. Before concluding your head-to-toe examination of the infant, be sure to return to any areas of examination that you had to delay because of lack of patient cooperation, such as the assessment of the motor reflexes or the otoscopic examination of the ears. Apply gentle traction on the pinna toward the back of the head. Hold the otoscope with the handle up between your thumb and first two fingers, resting the pinky and palm against the head. If the baby resists and turns his head toward you, the otoscope will be pushed away rather than inserted too far into the canal. In summary, the head-to-toe assessment of the infant requires a systematic but flexible sequence of steps, implemented with full awareness of the unique inherent challenges, combined with an approach that minimizes disruption to the patient.